So now topic for us is sequelae of wearing complete dentures. Sequelae means what? Sequelae means what will happen after wearing complete denture. What all problems you may expect and anticipate in a patient of a complete denture wearer. So the direct sequelae caused can be complete or from partial dentures, maybe mucosal reaction, oral galvanic currents, altered taste perception, BMS, burning mouth syndrome, gagging, residual ridge resorptions, periodontal diseases of the abutments, caries in the abutments. Coming to the first, that is denture stomatitis, also known as a candida altered denture. Also it can be because of irritational stomatitis. Now denture stomatitis, you can see in those patients who are the complete denture wearers, what happens, there is a layer of candida albicans which forms over the denture. Now that can be due to poor oral hygiene maintenance, that can be due to if there is porosity in our denture present. So denture stomatitis, maximum patient that is coming up is with the candida albicans. So the factors that is associated with candida associated denture stomatitis is systemic factors like old age, diabetic mellitus patient, nutritional deficiency who do not have proper nutritional deficiencies are present, malignancy like acute leukemia, immune defects of the patients whose immune system is not supporting for any oral hygiene measures. So in respect to oral hygiene measures which are not followed properly, what happens, there is this candida which comes over the denture. Then corticosteroid therapy, whoever the patient is following up. Local factors like dentures, changing the environmental trauma by the denture usage, xerostomia, those patients who are of Sjogren syndrome or irritational and having some chemotherapy, drug therapy going on, their saliva rate decreases. In those patients also we can see candida associated denture stomatitis. High carbohydrate diets, so what happens, like the rice and all, they go and stick into the particular denture, and due to uncleaning of the denture, there is candida associated denture stomatitis. Those patients who are prone to more smoking and tobacco eating habits, they are also prone to denture stomatitis. Now how will we prevent this? The first and foremost is informing the patient and also allowing the patient to maintain the oral hygiene, instructing and teaching the oral hygiene measures denture related, when the patient is supposed to remove the denture, when he or she is supposed to clean the denture, how much is the efficiency of the denture that is unclean, those are to be explained, and also to be shown what has happened intraorally so that the patient is beware of those consequences in the future days. Coming to the flabby ridge. Now how was a flabby ridge formed and why is it formed? Now flabby ridge is like, we all know that our body has an immune response system. Anything foreign comes to our body or anything harm happens to our body has a defense mechanism towards that. So when there is a ridge, then the mucosa is resilient and firm over it. Now when the resorption of the ridge is happening, what happens? The mucosa is overgrowing that particular area. So why is the mucosa growing? Because there is a body response which the body is giving as a defense mechanism so that the direct pressure is not on the ridge and it is increasing the tissue, that is the flabby tissue, the resilient tissue over there. Mostly this is happening in the maxillary anterior region. So we can anticipate flabby ridges in maximum anterior region of the maxilla. Now how will we get rid of this? The surgical excision is one good thing that we can get rid of this, but surgical excision doesn't help to take out the entire flabby ridge, because as I told you, it's a body response to the foreign stimuli or the resorption of the bone. So again it will come up with the same thing. Then the redundant tissue. What is redundant tissue? Redundant tissue is the cause of when resorption is happening. When resorption is taking place, so what is happening? The teeth is supra-erupting in focus of resorption. So when the teeth are supra-erupting, it is giving pressure into the lower denture bearing area and hence into the ridge again. So in this way again there is tissues which are forming, that is of very movable kind of tissue which is present. So those tissues are called redundant tissue. We should get rid of this redundant tissue actually, because it will hamper in the stability of the denture. The denture will start rotating and moving on to that because it is not firm. So it will start moving on to that. Denture irritational hyperplasia. Now, because of the irritation of the denture, there can be hyperplasia. What does hyperplasia means? Increase in the plasticity of the mucosa. So when the increase in the mucosa will happen, so where it will happen, where the denture spots are there, where there is occlusal discrepancies in those areas, there will be denture irritational hyperplasia. What are we supposed to instruct to the patient in these cases? We are supposed to say to the patient that remove your denture for the time being, let the tissues heal in that particular area. We apply antifungal therapies and other ulcer related creams and gels in those particular area. Ask the patient to maintain a good proper diet, do a massage with the help of your fingers with any toothpaste over the musculature and mucosa, and also keep the denture clean. So that is how we can help the irritational hyperplasia to go off. And most importantly, we need to mark the place because of what irritational hyperplasia is being caused and relieve it from the denture. Coming to papillary hyperplasia. The papillary hyperplasia is because every papilla has got retipex, we all know. So in those retipex, if they are increasing in the numbers, then there is an hyperplasia. There is a reaction of the body because of the denture. Some parts of the denture, like I told earlier, some part of the denture which has some projections, it is going to hurt that papillary projections all the time. So that will cause the retipex to destroy, and that will cause a ulcerative reaction in that particular place. So again, you need to do what? You need to go ahead with the removal of the denture, keeping it aside, massage of that particular place, relieving the denture in the area which is hurting, and then reinsert in the patient's mouth. Traumatic ulcers are oftenly seen in the patients after 1 or 2 days of placement of the denture. Once you are placing the denture, since it's a new body, what happens, acrylics sometimes have a property of leaching on monomer. So once the monomer is leaching, that goes into the mucosa, and some mucosa are hyperactive. So those mucosas get redness and there is ulcerative patches in the entire mouth. So that can also be done the same thing. Ask the patient to remove the denture, keep it clean, and also massage the particular area, see for any high spot, anything in the intaglio surface which is causing any irritation, and then relieve it. Coming to oral cancer in denture wearers. So in oral cancer, oral carcinoma has been seen having association with the denture wearers. But in all denture wearers, does oral carcinoma happens? No. It happens to the ill-fitting denture wearers. The oral carcinoma is more commonly seen. Now, just because ill-fitting denture, can there be oral carcinoma? As all doctors, we know that no, it has to have some predisposing factors like alcoholism, smoking, tobacco chewing. All those habits can gain up to the oral carcinoma in the particular patient. Coming to burning mouth syndrome, a very important thing to understand. Burning mouth syndrome, as the name suggests us, burning mouth. The mouth itself is going to start burning. Now, is there any difference between burning mouth syndrome and burning mouth sensation? Yes, there is. In burning mouth sensation, you will see the entire oral mucosa inflamed, reddish. Whereas in a burning mouth syndrome, the mucosa appears absolutely healthy, absolutely healthy. So what happens in burning mouth syndrome is that the entire mouth is starting burning. Now this is a very careful thing as a prosthodontist or a dentist to undergo and execute your problem. The thing which the problem or the chief complaint which the patient is giving you is burning mouth. Now you see no inflammation onto the mucosa. What are you supposed to do because of that? So what you need to understand for that, what are the factors that are affecting burning mouth syndrome? So there are certain factors like local factors, mechanical irritation because of some denture that we can relieve, allergic infection of monomers that we can do help out, oral habits and parafunction, that is something that you need to teach the patient not to do. Myofascial pain, then that is something severe that you need to understand and execute accordingly. Systemic factors like vitamin deficiencies can be present. Iron deficiency in females more than age of 50 can be anticipated for menopause and psychological disturbances. So in those cases, and diabetics and Parkinson's cases where the patient doesn't have his own control over to the musculatures and medication related. It can be due to psychogenic factors as well, like depression, a patient who is very anxious, a patient who has a psychological stressed out factor. In those patients also we can anticipate a burning mouth syndrome, and in those patients it becomes difficult for a prosthodontist or a dentist to manage the burning mouth syndrome. Now, to manage a burning mouth syndrome is again the same thing, because reason remains is the syndrome is burning mouth, but you cannot see any symptom in the patient. So that is the reason you need to take it very carefully, and you need to see for what reason this is happening. If something is denture related, we can correct it. If something is psychological related, that needs your more care towards the patient. Gagging. Gagging is normal. It is a normal human tendency, or you can say it's a healthy human response to any foreign object which is coming into the trachea. So immediately they gag out. It's a good response by the body. So gagging to a limit is normal, but gagging always due to the denture requires your own precision in that. And how are we supposed to do that? We will understand this in the very first step when we are making the primary impression. While we are making the primary impression, the patient starts gagging. In subsequent appointments, you will find if the patient has got gagging, first clear and make the patient adapted to that particular material that is going to come to his mouth or her mouth. That is acrylic. So how will we do that? Give acrylic plate for some days to wear before you deliver the denture and insert and place the denture in the patient's mouth. So also you can use a marble technique. Marble technique is you take small marbles, you ask the patient to put it in the palate, and firstly 1 marble, next week 2 marbles, 3 marbles, and like this when the patient starts getting adapted to any foreign object, the acrylic will stay well in the patient's mouth. Coming to residual ridge reduction or residual ridge resorption, Atwood had given a good classification of order 1, 2, 3, 4, 5. Say, how does it go about? Is pre-extraction, then extraction, then post-extraction. Then what happens? There is a ridge which is present, which is high, well-formed ridge. Then what happens? Then you see a knife-edge ridge. Then you see a low round-formed ridge. So this is how the reduction in the residual ridge goes on taking place. Now this rate of residual ridge resorption can increase because of some mechanical factors, anatomical factors, physical factors present in the body, like damping effect can decrease the rate of the resorption. Any detrimental effect on the occlusion can even increase the resorption rate. If the teeth which is arranged not in a proper position, that will increase the resorption rate. If the patient's habit has got a parafunction, that will resolve the resorption of the ridge. Now coming to the indirect sequelae of wearing a complete denture. So atrophy of the masticatory muscles using the denture to and fro and all the time, what will happen? These musculatures will get atrophied. So they will get very weakened off in time being. There can be nutritional deficiencies. Why? Because of denture can there be nutritional deficiency? That is because in a denture wearer, if he is not able to properly masticate, he will not have all the amount of right food. And if the right food is not happening to be undertaken by that particular patient, will of course get nutritional deficiency. So we can expect nutritional deficiency if the denture is not proper. If the mastication of the patient is not going proper, we can absolutely expect nutritional deficiency to come over in the patient's mouth. And masticatory ability is one important thing which will determine that factor. So if the patient is able to chew properly, he will have all the food. If he is not able to chew, why will the patient not be able to chew? The teeth that we are arranging should be in a motor basal way, where it can, grind the food that is coming inside, the bolus that is coming inside the mouth. Now, if the teeth and the cusp in the fossa relation is not proper, the grinding is not going to happen. If the grinding is not going to happen, so the food is not going to get masticated. That is grinded. So the patient cannot eat the food properly, chew the food properly. So the motor and pestle effect is very important in the molars to find out the proper masticatory function. Coming to the nutritional status and the masticatory function. Of course, if the masticatory ability of the patient is decreased, the patient cannot have food. If the patient cannot have right amount of food, the right amount of nutrition will not reach to the particular patient. So masticatory function and oral health is very important, and based on that oral health, your general health is going to suffer because the patient will get weaker. There will be vitamin deficiencies, there can be other deficiencies, there can be iron deficiency. This is how his socio-economic health is also going to get suffered. He is going to suffer from other diseases. He is going to suffer from other diseases which will be coming over because of this nutritional deficiency. Also, he will be altering his dietary habits. Now, because a complete denture wearer cannot have a denture in every 2 months, he will have to adapt himself to the denture. So, once he's starting adapting to the denture, what will he do? Either he will start eating less of those foods which get chewed by the denture, or he will start removing the denture and not having the food properly. In both the ways, we are compromising with the nutrition. Once the nutrition is compromised, our oral health is compromised. Once the oral health is compromised, the entire general health is into stake. So control of sequelae with the use of complete denture is very important, and it is important as a part of a dentist and a prosthodontist to make your patient understand how a complete denture is going to affect his oral and general health. So, if there is any sequelae because of the complete denture, that has to be relieved and taken seriously very soon. In the recall appointments, you are supposed to make a recall in after 6 months and then next 6 months. According to Mellon's classification, it has been classified how you are supposed to get a recall done. So, the sequelae can be controlled, but for that you need to have a keen observation on the high points, on the occlusion, on the peripheries of the denture, any candida that is coming over the denture, any other organisms which is coming and inculcating into the denture because of your denture porosities and other irregular surfaces in the intaglio part of the denture, or is there any inflammatory reaction which is happening inside the mouth in the oral cavity because of the denture. All these are supposedly to be examined after 6 months to keep the health of the denture, health of the patient and the oral health proper in a position. Thank you so much.